Thanks everyone for joining us today for the Minnesota Public Health Association's Vaccine Hesitancy, What Can We Do uh, webinar. My name is Matt Flory. I'm a co-chair for the Policy and Advocacy Committee for the Minnesota Public Health Association. We're going to ask you, since we are recording today, to please, and just out of courtesy for everyone else, please mute your microphone when you're not talking. It's really up to you if you want to be on camera or not. We are going to record today, so if you don't want to accidentally be caught on camera, we just want to give you that cue. If you feel comfortable, please rename yourself to include your pronouns, and you can put questions and comments in the chat. We should have time at the end of the presentations today for presenters to answer questions. We do start every MPHA meeting with an ancestral land statement, so I'll read that quickly. We ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a long-standing history and connection to the land since time immemorial and are the original steward of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and U.S. governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors, and descendants, as well as the land itself. I'm going to introduce briefly our speakers for today and ask Dr. Jones to go first and then Karen to go second. Garret Jones is board certified in pediatrics, and his clinical interests include preventive medicine, asthma management, and caring for medically complex children. He's also the chair or co-chair of the immunizations committee.
Just chair right now. I don't have a co.
Okay, chair. And Karen Ernst is a nationally recognized expert in vaccine confidence with a decade's experience in grassroots organizing around this issue. Thank you so much for joining us today. And I'm going to stop sharing my screen and see, Dr. Jones, if you can pull up your slides. If not,
Yeah.
I have them ready too.
Let's see. I've got my slides. Let's see if we can share. Okay. Can you guys, I'm assuming no one can see what I'm doing, because that would be far too easy, wouldn't it? Let's see. Can you see? No. I'll try to share one more time. You can see?
Yep.
Perfect. All right. Let's go ahead and get started. So, again, as Matt mentioned, I'm a general pediatrician. I work at a clinic called Pediatric Services in St. Louis Park, and I've been doing work on vaccines and vaccine hesitancy for really the last probably 7 or 8 years or so, and done a lot of work even with Matt on some HPV-related hesitancy issues and really just kind of hesitancy in general. So I will try to keep it kind of short and sweet, but I can talk about this stuff for hours. So my apologies in advance. So big picture first, we'll talk about what is hesitancy, what is the problem itself, what are some of those main reasons, and then kind of shifting more to kind of the what do we do about it, thinking about what about the different levels of engagement. I'll kind of describe what I mean by that, and then I'll give you kind of a foray into what we do here in the primary care office, where I'm currently sitting too. So the vaccine hesitancy is I call it a tale as old as vaccines. So this is actually a cartoon from the Anti-Vaccine Society that was published in 1802. So this was 6 years after Jenner's first successful smallpox inoculation. And as you remember, with the using cowpox as for the inoculation, that people were concerned that they would develop into cows and horns and all sorts of things. So the anti-vaccine, the push to kind of discredit vaccines has been around from the beginning. So it always feels like a newer topic, but it really has been for a very, very long time. There's multiple definitions of vaccine hesitancy in general. The World Health Organization really talks about the declining of vaccine when the vaccine is available. I like this definition from Heidi Larson. She's a professor at the London School of Tropical Medicine and has done a lot of work with vaccines and vaccine hesitancy over the years. And what I like about it is it highlights a couple of things. One, that it's a state of uncertainty. So it's not necessarily that people say, a hard pass no. It's a I'm concerned, I'm uncertain, I don't know what to do. But also the second sentence there, representing a time for vulnerability and opportunity, meaning that what can we do to change people's minds is really important. This is not a Minnesota problem. This is not a US problem. This is a global problem. Back in 2019, the World Health Organization designated vaccine hesitancy as one of the top 10 threats to global health. And a lot has changed in the world in the last 5 years, but I think we would all agree that vaccine hesitancy is probably on the rise now, comparatively, especially with COVID and the COVID vaccine. Well, the other important thing to know is that with the World Health Organization doing a lot of work in vaccine hesitancy, really tried to understand better about what helps. And what they found, and this makes absolute sense, is that one single intervention is not going to do the trick. It's not that we say the one thing that's the right way to do it, or we have one perfect public health initiative and that's going to fix all the problems. That's not the way this works. It's a multi-component problem where it's frequently we have to think about this in kind of that individual dialogue-based or targeted interventions. And so thinking about this kind of more broadly, all the different pieces of the puzzle is important and not just relying on one thing. So where are we at? So this is data from what's called the National Immunization Survey. It's just looking at where we stand. And these are birth year cohorts. So these are kind of across the bottom. And this is looking at kids when they're 24 months old and they turn that age. Are they up to date with these vaccines? And we've had some improvement actually with hepatitis B vaccine, so good job. But we've also seen a bit of a decline. This kind of represents where COVID was. And as we all know, there's been a decline in vaccines for a number of reasons since the pandemic. What about Minnesota now? We stand here. So basically, when we look across the country, we see that Minnesota, yay, is doing well. So comparatively to other states, our vaccine rates are higher. This is the vaccine series. This is not the same as the combo 10, just to point that out. But this is kind of the way that a lot of the vaccine data from the NIS is kind of looking at broadly, how are we with a number of different vaccines? Are we up to date? And you can see we're about 76%, which is good. But if we remember herd immunity, that is not good enough. So we really need to get higher. Now, some of the time we're doing great. Polio, greater than or equal to 3 polios, we're doing quite well. Others, we're not. A full series of Hib, we're lower than 80%. With hepatitis A, we're lower than 80%. So there's certainly a lot of room for improvement, even though Minnesota, we are doing better than the average across the states across the US. This is using the same data, but looking at it specifically state by state. There's a CDC publishes this kind of data, and it's called the Child Vax View, which I love because it's great to see the different states and kind of how we compare. You can look at specific vaccines. You can look at, again, this is just looking at that big combo series. And again, we're doing better than others, but there's still room for improvement too. The other thing that I think does well with the CDC data set is that we can see what are called non-medical exemptions, which is a problem here in Minnesota. We are one of 15 states that allow for non-medical or what's called personal belief exemptions. So you can see that our rate is about 4.5%. So it's hard to see based on this because there's big data ranges, of course, but our rate is about somewhere in 4.3, 4.5% of kindergartners who have a non-medical exemption to one or more vaccines. And again, these are not medical exemptions, these are others. So we are doing better than, let's say, Idaho at 11%, but we certainly have a lot of room for improvement. And this is something that even on kind of a statewide basis, we've been working with. The Minnesota chapter of the AP has been working with the legislature for years to try to repeal the personal belief exemption. And it is so far unsuccessful, but we are continuing to try. It is always a top priority for us because if you think about our rates are, again, we're above average, but we could be even better if we can repeal the non-medical exemption allowance. So important to keep that in mind too. This is, I highlight this. This is data from the National Immunization Survey, looking at this kind of 8 to 9 month period back from 2021 to 2022 about vaccine hesitancy. I use it to highlight the fact that, so yes, COVID vaccine hesitancy is quite high. We all know that. But the rate of RCI, in this case, RCI, routine childhood immunizations, hovers somewhere around 20 to 23, 25% on average. And this is true, and this data has been borne out in other studies as well. And those are people who self-identify as vaccine hesitant. If you look at other studies which just ask the question, do you have any concerns about vaccines? Do you have questions about vaccines? The number is often double that. It's often 40, sometimes up to 50% or more of people who have questions. They may not identify as a vaccine hesitant, but they are still having questions. So it's something that we always have to be thinking about in the office of, okay, how do we approach people? Because people absolutely have questions. So why do people choose not to vaccinate? A lot of it comes down to the broad product, concept of kind of vaccine misinformation. It's safety concerns. It's the debunked link between MMR and autism. It's what about aluminum in vaccines? People ask me all the time about thimerosal still. People worry about side effects. What about, my 2-month-old, where you're giving them so many shots at one time? Is this okay? Is this necessary? When's the last time you saw diphtheria? I was actually asked that in the office the other day, and I said, I've never seen diphtheria, and I'd like to keep it that way. So there's, unfortunately, kind of vaccines are a product of their own success, and unfortunately, there's the concern that natural immunity, in quotation marks, is superior. And then this one comes up a lot with the COVID one, but also HPV as well. If it's new, are we sure this is safe? What do we know? And again, falls under that category of overall vaccine misinformation. These are not the only reasons people say no. We'll get to that in here in a little bit, but these are kind of the main ones we think about when we think of the concept or the kind of the big picture of vaccine hesitancy. What can we do about it? I like to think of this kind of upside down triangle. What can we do on a broad spectrum? What can we do when we kind of come down to individual communities? And then what about in the office? Or what about in an individual, not even a pediatrician in an office? What can you do walking around town or at a family barbecue? What can we do at an individual level to combat this? So a lot of great organizations, shout out to Karen and her organization here, but there's a lot of great work that's being done on both the national and the state level. It is always a work in progress. There's always things to be done. But these groups are wonderful, and countless others about advocating for vaccines. When we come down to the community level, it starts to think about, okay, how can we target our approach to a specific individual or to a specific individual's community? So I highlight, this is all stuff from the Minneapolis Health Department around the COVID vaccine, which I really love. It's talks from the Somali doctors about the importance of vaccinating. We look at the kind of the cartoons there on the left-hand side and targeting why specific communities, what is important to that community. So in the Asian community, maybe it's about the wisdom of our elders and taking care of our elders. Let's tap into that and say, okay, well, by vaccinating, we can help protect them. That may not work for every subgroup. That may not work for every community. So what works in each individual community, and then targeting that specifically as a way to address hesitancy. And then on an individual level, I mean, it can be as simple as you're walking through the office and someone says something that doesn't make a lot of sense about vaccines. You can say, wait a minute, let's talk about this. Or maybe there's your crazy Aunt Edna at your family Thanksgiving dinner that says something that's off the wall, and choosing to engage in that moment is important. But sometimes it's even just reaffirming. It can be, your cousin or a neighbor has a new baby, they're taking to the pediatrician the first time, and they're saying, oh, I'm a little nervous, I know that's a lot of shots. Say, I'm really proud of you, that's awesome, that's great they're getting their shots today, that's wonderful. And so just reaffirming the importance of this, even in more kind of subtle ways than we think of as almost combative. So what about in the office? This is pediatric services. This is our office here. And so what do we do in the office? If we take that same kind of reverse pyramid and we think about what are the big picture stuff. So we want to make sure we create a pro-vaccine environment, meaning that everyone, the whole staff is aware of the importance of vaccines, talks about vaccines in a supportive way, that the information on our website is about, is pro-vaccine, the literature we give, all of that. So you can create this environment, the whole atmosphere itself is pro-vaccine. And then we come down to kind of the more community-based level. So more targeted outreach, or figure out what best practices work for certain groups versus others. And then it comes back down again, that kind of individual in the office when I'm talking to someone, a specific family. Really, the most important thing when it comes to how I communicate, and this is true for anyone, not just pediatricians in the office, but anyone, when you talk about it, communication is key. It's how we connect to another individual that is going to be often the difference of someone saying yes and someone saying no. There's some strategies and some frameworks about how we communicate that are helpful. I'll highlight things like being presumptive, being persistent, make sure we're clear. Sometimes these discussions in the office can take many different angles and turns, and we sometimes have to make sure we bring it back to, all right, here's the crux of what we're going to do, what we should do today. So being clear. I always tell people, don't overshare, because frequently, if you have a lot of information about vaccines and you feel strongly about it, you can data dump. And so sometimes we can just unload our entire brain of information on someone, and all they really wanted to know was to hear you say that vaccines are safe, or that side effect is not common. It could be something as simple as that. It doesn't need to be what study from Great Britain about transverse myelitis and the HPV vaccine. Like, you don't need to get into that nitty-gritty detail. But be inquisitive, ask questions. It's important that we build the connection with families, because even if you don't get them to say yes today, if you can build a relationship, build rapport through successful communication, then maybe not today, but maybe tomorrow, or maybe next time they come into the office. So this is a long game in a lot of ways. And then motivational interviewing. Karen's going to mention a little bit more about this specifically, but I highlight it because it's really important. What does it mean to be presumptive? Now, this is the past about 10 years is when the idea of kind of the framework of starting a vaccine discussion has been kind of in the forefront of vaccine hesitancy work. Being presumptive means that I assume that a family is going to say yes. So I would say, like, your child is due for 3 shots today. I don't say, how do you feel about shots today? Because then that kind of makes it feel like, well, is it questionable? Maybe I shouldn't do this. If my provider doesn't feel strongly about this, then maybe I shouldn't be doing this, or maybe I should have questions, instead of just making the assumption that they're going to say yes. And if people do have questions, they will ask, absolutely. But it's important to start that way, that presumptive approach. And it's really shown time and time again, it's very helpful. There's data from the HPV vaccines, there's data from the initial childhood, kind of the early immunization, early infancy immunizations that helps. It's really been a very effective strategy. Persistent. This is my shout out to Tom Petty. I won't back down. Basically, making sure that if you meet resistance, we don't just stop. It's not okay, you said no, I'm done, no more. Maybe we'll talk about it next time. We want to make sure that we push a little bit, because if we don't, then families think, well, maybe it isn't that important. I had a question and then they backed off. It can't be that important. If it was really important, they would tell me. And so when we think of it from that perspective, if we push back, and again, in a non-judgmental, a very respectful way, then we're much more likely to get people to say yes. This data is remarkable. This data shows that over 90%, but other data shows somewhere between 40 and 50% of people will ultimately decide to vaccinate that same day. So would be missing a large chunk of people if we just say yes, saying yes to their no the first time around. So again, I don't want to delve too much on motivational interviewing, but it's a really effective communication strategy about how to kind of change people's minds. We have a goal where we want them to get to, and getting them there themselves is really the crux of it. And this again has been shown to be helpful with vaccines in multiple studies across across different settings. What happens when you meet resistance, though? I highlight this because this is everyone's brain when you hear someone bring up aluminum in a vaccine, or you hear someone say, I don't know, that seems like a lot today. Like, our brain literally goes, what happens? We often choose not to engage because it's a time issue. It's the patient came 10 minutes late and your next one's already being roomed, and you're like, I don't have time for this. Or that you're going to ask me some crazy question that I'm not going to know the answer to, and then I'm going to feel silly, and then they're going to think I don't know what I'm talking about. We often feel fatalistic. They have questions, they're going to say no. What does it make a difference if I spend the next 10 minutes blabbering your ear off about the importance of this if you're ultimately going to say no? And then I highlight the last one of it's the world we live in. It's a patient satisfaction driven world. And so oftentimes in the office, we know that the moment they walk out, they're going to get a survey. And if we just spend time in kind of maybe an uncomfortable conversation about vaccines, are they going to give us a bad rating? We shouldn't think about that, but that's the world we live in. But remember, we can change minds. We can do this. So I kind of alluded to this earlier, but is it just all misinformation? Is it just that there's too much Joe Rogan? Is there too much other stuff going on out there that that's driving this? And that's not the only reason. And we have to be aware of the other reasons for a delay in a vaccine. Again, whether this is a true hesitancy on the part of a parent or this is some other issue, we have to be aware of this too. So a lot of people don't have a medical home. They don't, or they have scheduling issues. They can't get in. The flu clinics are only on Tuesday afternoons and they can't get in because that's the day they work. So being aware that's a reason that sometimes people, either can't come in. Transportation issues, same kind of thing. People, I hear it all the time, parents of little children, they say, well, I don't want to cause my baby harm. Like I don't want to hurt them. And so they may know the importance of vaccines. They want to vaccinate, but they're really worried about doing shots for the baby and it's going to hurt. And so how can we address that? And there's ways in the office we can use numbing creams, we can use distraction devices. We can do comfort holding positions for kids, breastfeeding while you're, there's all sorts of things we can do. But if you don't know that that's the problem and that's the concern, then we're missing it. If we just hear they have a question and we don't ask why, then we're going to miss out on that. Needle phobia is a huge problem for especially the older kids. And again, if that's parents often will tell me, like, listen, I know they need their HPV shot, but I can't fight that battle today. I'm tired. We've been through a lot, or whoever. It's the end of school. I can't fight that right now. And again, if we don't know that that's the problem and we don't have ways to address that, then we're going to miss out. It's not even that they don't want it; it's that they aren't going to get it. Ultimately, that still causes the same problem of under vaccination. And this one, I always highlight this because people bring this up all the time. Oh, my child's got a cold. We can't get a shot. That's not true. The CDC has actually published some wonderful data that I'm sure you all know that basically, unless it's a really extenuating circumstance, unless I'm sending you to the hospital, we should vaccinate today. And I tell people that all the time, and it's safe to do it. But that can often be a reason that people kind of shy away, and it's okay to push back on that. So last, I just want to highlight one of the things people often get worried about. Well, what happens when things get heated? People get upset. These conversations, unfortunately, as we all know, can be tense. And so what do we do in those scenarios? So my thing, and I say this all the time, as I say, build the empathetic bridge. And what I mean by that is, I care about your child. You care about your child. Let's meet in the middle. We both care. And by expressing empathy for someone and really kind of getting at their level and understanding where they're coming from, acknowledging that they are the experts of their children. I may be the expert on vaccines, but they are the expert of their children. And so kind of finding the way to connect those two is really important. I also always like to, tell them, I know you care about your child. I do too. And I wouldn't do anything for your child that may hurt them or harm them in any way. And so making sure that they know that I care. I know that they care. It's not that I think they're crazy. It's just that I think that we're trying to find the middle ground there. That helps. Again, whether that helps today or whether that helps next time or 2 years from now when they ultimately come back and say, okay, fine, let's do those MMR shots now. That is, you can't lose sight of that bigger picture. And this is a good way to remember that. But remember that boundaries are important too. Sometimes we have to say, listen, you can't talk to the staff though. You can't talk to me that way. I've been yelled at in the office. I'm sure many of you have been into the same circumstances too. And it's okay to establish boundaries. And you can even say, listen, I know that this is very important to me. This is an important conversation, but I can see that this is not a good time to have that. And maybe we can have that at another time. And so you can still engage with them, but knowing that may have to set some healthy boundaries. So I want to make sure we give plenty of time for Karen as well, but just wanted to highlight all that and knowing that, again, these are multifaceted problems with multifaceted solutions. And so thank you all, and I'll turn it over to Karen. Let's see if I can stop sharing.
Thank you so much, Dr. Jones. Everybody, go to your react button and do the applause sign for him. And I will get my sharing screen up. All right, I think I'm sharing the correct screen. You see that? Fabulous. Okay, so I am going to be also talking about vaccine hesitancy. This is where we're going. What is vaccine hesitancy? Talking about it from sort of a little bit of a different angle, how it happens, and then the fastest motivational interviewing course of your career. And I won't say the only one you need, but the fastest one. Okay, so I just want you to consider, I know you've seen this a bazillion times, but just to have this in your mind as we're going through here, that it is a spectrum that you can have on one hand, someone who goes out, talks to people about vaccines, wants everyone to get vaccinated. On the other hand, goes out, tries to stop everyone from getting vaccinated, like actively tries to, ban mRNA vaccines from everyone in the world, yells at people for getting vaccinated. Those are the rarities. In the middle, basically, we have people who have, going out, getting vaccinated, never saying anything to anybody about it, or not getting vaccinated, never saying anything about it, or getting vaccinated and being like, I guess I got vaccinated, but I don't know, is it okay? Lots of questions in the middle. And that's sort of who we're talking about today. People getting vaccinated, having questions, not getting vaccinated, having questions. Everyone deserves to get vaccinated and feel confident about it. And that's what we're targeting, is people feeling good about getting vaccinated and getting vaccinated. Alrighty, so I have sort of made 4 buckets based on my experience of talking to those confident vaccinators and the people who used to be not so confident refusers who became confident vaccinators about the top reasons for hesitancy. And we've put these buckets thus: negative healthcare experiences, media or social media bubbles, peer group influences, and historical or cultural backgrounds. And so I just want to briefly go through each of these. So the negative healthcare experiences, I really want to emphasize that this doesn't have to be a provider's fault. It doesn't have to be like, I went in and my doctor was a jerk and now I think all doctors are jerks. Although that can happen. Certainly, we all know that there can be, doctors, nurses who are not great. But it can be something like, I went in, I had my birth plan, it was going to go great, and the baby didn't cooperate with the birth plan. I don't know why. It was a great birth plan, and it was awful, and I just don't trust healthcare now because it doesn't seem like things work out the way they're supposed to. Or I went in, the insurance didn't cover things the way they're supposed to. I feel like the odds are stacked against me. I don't know how to access things the way I can. I don't trust healthcare. Or like me, I'm trying a new med now, and my brain feels like it's turned upside down and everything is weird. And I'm going to stop trying this new med, by the way. So, all these sorts of things can happen, and it puts you in this place where it's like, healthcare, thumbs down. We have one study. I always say we have one study and then I never pull up my notes. I will put it in after I stop sharing. I've got one study that found that basically people who have access regularly to your ears and your heart are able to influence your decision to vaccinate more than the person who's got the degree and the authority and the knowledge. So that doctor that you see a couple times a year or every 2 months with your baby has less influence than that mother-in-law who calls you every day and brings you cookies and washes your dishes for you as you're holding your baby and says, oh, those vaccines are terrible, don't get them. I mean, it just works out that way. The people who love you and have access to, again, your heart and your ears can really sway your opinion more than that doctor who actually knows a thing or two. And that's just the way that it works out. The more people we have in our personal networks and our peer group who don't vaccinate, make that norm for us, make that social norm for us, and make it seem like, I guess that's what we're supposed to do, is not vaccinate. That is the norm. And it really makes it difficult for our doctor to sway us into that position. And I should say provider, because really want to make a nod to our public health nurses and our nurse practitioners and our other nurses. Alrighty. And so we have another analysis that found that if you're under 65 years old and you watch Fox News, you're much less likely to get a COVID vaccine. And that's not true of flu vaccines. And that's just because of what you're hearing on Fox News. That's your media bubble. It's also, I don't think we're going to be shocked here, really, really true of your social media bubble. That's that algorithm that, Facebook says to you, you seem to be a person who probably hates vaccines. I'll deliver a whole bunch of this, like you don't like vaccine stuff to you. And then guess what happens? It's a self-fulfilling prophecy. And so the take-home lesson, of course, is that social media is terrible, but actually the take-home lesson is that we no longer share the same group of facts because we don't sit down and watch the same nightly news every night. We don't have 3 channels that we all share. We have thousands of channels and we don't share them. And so we're making truth based on completely separate bubbles of facts. And we are coming to conclusions about vaccines based on those bubbles. And so our identities are all wrapped up in those bubbles, and we are going to be really, really tied to those bubbles. And by the way, if I just go backwards, probably has a lot to do with our peer group influence too. And then lastly, historical and cultural reasons. Dr. Jones mentioned a Joe Rogan video. I was watching a Joe Rogan video. In the video they mentioned, of course, the Tuskegee syphilis experiment, and that gets mentioned a lot. But I've heard from a number of people in various Black communities that has a less of a hold on people's vaccine decisions than a lot of people imagine, although it's brought up a lot by folks. I think a lot of the times that the cultural reasons can be things that are less obvious, things that we don't see necessarily, such as if you're a Black woman, you're much more likely to die after childbirth than a white woman would be, and your pain is much less likely to be taken seriously. And so if you go to a doctor and the doctor says to you, you should vaccinate your child, well, you haven't believed me for a while yet. I'm going to have trouble trusting you. And so those are some of the cultural things that are baked in at that point. And this book, if you haven't read it, is about a Hmong family actually in the Central Valley in California. It's called The Spirit Catches You and You Fall Down. It's about a Hmong child with epilepsy. And it's a very sad book, I should say, because if I ever recommend a book to you, it's very sad. But I think anybody who works in medicine or public health should read it because it is really instructive on how everything can go wrong because of culture. And it's a real thinker because those cultural reasons can be entirely different than what we imagine they could be. And we really should think about all of the ways that people get discounted because of the way they look, because of where they're from, because of how they speak, because of their educational background, all of these things. We really need to think about that, and we really need to be good listeners, and we need to consider that culture is coming into exam rooms as well. And we need to treat not only the person, but all of those cultural things that are coming in too. And that's really easy for me to say because I don't have to treat anybody in an exam room. I just want to say you're all doing a great job and I appreciate all of you. And it's really easy for me to say those things. So thank you for letting me say them. All right. Oh, wait, how did I get here? Oh, no. Okay. I'm going to do one of my slides is totally, yes, all of my, okay, my first slide on my 4As has fallen out. I am going to shift over now to teaching you the fastest motivational interviewing that you've ever seen. Unfortunately, one of my slides got deleted and I don't know how. So I'm just going to talk you through this next slide and then I'll go to the next slide. So when we do motivational interviewing, we call it the 4A method. And we call it the 4A method because when someone comes at you and says, and you've done your presumptive introduction to the vaccines. You've done their weight, you've told them that their kid looks great, that they're clearly above average because they're a Minnesota child, that they're handsome or beautiful, and that they're charming, and then you say to them, your child is due for these however many vaccines today, and then they say, well, no, thank you. And you have to take a deep breath because you think to yourself, uh-oh, this is going to be one of those. So you take that deep breath and then you think to yourself, oh great, now I have to do motivational interviewing, which is this whole big thing. Now I have to say, and I see Fatuma is on here, and she and I have both worked with Arnaud Gagnère quite extensively. And he's sort of the guy who wrote all of those motivational interviewing papers, and they're very detailed. They're quite intricate, and so you're probably thinking to yourself, the vaccine ones anyhow, you're probably thinking to yourself, okay, I have to get into my motivational interviewing framework. And my motivation to doing the 4A framework instead is to think, how can I make this simple so that you can just do 4 things and not have to think too hard and stay calm and just take them through. So we have 4 A's: ask, acknowledge, affirm, answer. You can remember that. First of all, they're all verbs, which I really love because they're all things that you do. And we're going to start with asking. So we want the other person to talk. We don't want to hear ourselves talking. We want the other person to talk. It does a few things. First of all, you're still thinking, uh-oh. Or, if you're like me, you're thinking, uh-oh, SpaghettiOs, just because you're trying to calm down and you're trying to lighten the mood inside your head. So to get the other person talking, we want to think to ourselves, I need to be curious. I need to be non-judgmental. So I'm going to ask an open-ended question. I'm not going to think about how I'm going to respond. And I'm just going to listen and look for an opportunity to ask another open-ended question to drill deeper. And if I get to the point, I'm going to try to ask them to pinpoint their main concern. We're going to try to drill down to one main concern that we can get to. Just drill into it. So what's behind their hesitancy? Listen. Listen. Don't think about how to respond. Just, get some more questions out there, not working super hard at thinking of an answer. And then, more bridges. Dr. Jones and I love bridges. And we don't have bridges to sell you. We're giving them to you for free. So you know that this is the right thing here. Like I said, we're listening carefully. One of the things we're listening carefully for is something they've gotten right. Anything they've gotten right. Like, Lord, say something right so I can acknowledge it. We also want to acknowledge that they're right for digging and that we respect them for digging into their research, for looking into vaccines. We want to acknowledge any correct information they have. We want to acknowledge that they're capable of making good decisions for their kids. Anything that's right about what they've said, acknowledge it. We're like their cheerleaders. This is how we also, like Dr. Jones said, this is how we try to get around that hostility, maybe head it off before it starts. And then we want to affirm them. We're building trust here. It's okay to have questions. It's okay to not be sure about vaccines. Plenty of people have had that concern before. Maybe you had that concern. Like, I heard that about the vaccine and I too had that concern and I looked into it. Or doctors heard about that and they looked into it. Or maybe even like, you know, the CDC had that concern and they looked into it. Some, you know, or if someone had that concern, certainly it would be something to look into. Whatever it is, it's okay to have that question. It's okay to talk to me about that question. It's okay to look into those things. And it's definitely okay to talk about those things. But an affirmation that, you know, you don't just like swallow that and get the vaccine anyway. We definitely talk these things through. Ask, answer, affirm. No, ask, acknowledge, affirm, and then answer. And this is the really important thing about the answer. It's the answer is sometimes actually called the ask, offer, ask. So we want to get permission to provide an answer. We don't want to provide an answer without permission. And this is how I frame it for people who feel like this is awkward. Actually, one of my staff members hates this. She's always pushing back and she's like, "Oh, it's super awkward." And like it's not really. Because if you ask for permission, you say, you know, can I offer you an explanation or whatnot? And the person says no. You're like, cool. And then you end the conversation and then you didn't waste any time because now you can just go on with your life, right? Like, since you're like, oh, okay, cool. Well, you know, done with this appointment, done early. Maybe I'll get to lunch early to this today. Nice. Have a good day. But if they say yes, then they've softened a little bit, right? They you know, yes, you can talk me through this. Then they're a little bit softer, and you can provide them with that answer, and it's not combative. So if it's possible, you can help them arrive at the correct answer, you know, using that Socratic method. None of us went to law school here. That's, you know, why we're all good people. I'm kidding. I hope none of you are married to lawyers. But you know, sort of, but usually we don't have enough time to use the Socratic method. So, you know, we can provide them with information. I like to help people understand how the vaccine works in the simplest terms. So, you know, the Joe Rogan video was saying that the spike proteins, like you inject the spike proteins with the vaccine into the body, and then the spike proteins go into the nucleus of the cell and then they build up and they cause cancers. Whereas we know it's the mRNA goes into the cytoplasm, which is the outside of the cell, and the spike proteins, you know, show themselves on the outside of the cell, and then the immune response is killing off the spike proteins. So it's all good. And when people hear that, like, all of the misinformation sort of melts away. And then if you don't know the answer, one of the things that you can get permission, the way to get permission is, I'm not sure what the answer is. I would really love to do some more looking into this. Would it be okay if I looked into this with sources I trust and get back to you? And I really think that is a really decent way of talking to people, even if you're in the clinic. You know, I think that it's okay to admit, I don't know the answer, but I'd like to look into that. I think that's a really respectful way to talk to people, and definitely get back to them. Remember that answering is the last step. I like to tell people that I think sometimes answering is the least important step. I think that listening is the most important step. And then, you know, it's called the ask, offer, ask, because it's a nice little tag you can put on the end, if you remember, is, now that you've heard that, what are your thoughts now? And then they're supposed to say, I think you're a genius and I really want all of the vaccines. Maybe not like that, but, you know, hopefully they might come back to you with another question, or they might, you know, say, okay, I feel better. And this was, okay, so this is where I'm telling you, I tried a new med. There's something wrong with my brain. All right, so I want you to see what this looks like. I'm going to go through this kind of quick because we're going a little over time. So a mom comes in and says, my son is a young man, and I'm concerned that if he gets the vaccine, he is at risk for cardiac death. Okay, this is something that you could hear. So you ask, you probe deeper. So these are possible things you could ask. Is the concern about cardiac problems your only concern? Or can you tell me more about why you're worried about cardiac problems? All right. And then she tells you more. You might say, I'm going to say the third one is my favorite one of these. You are correct that there's a slightly elevated risk of myocarditis and pericarditis, or a swelling in and around the heart. So she's right that there are cardiac concerns. So we acknowledge that. And then we're going to affirm her journey. A lot of people have had this concern because it's made the news. Or when the data first came out, a number of scientists were concerned about the risk and looked into the issue. Or it's completely normal to hear these stories and worry that your son could have a cardiac issue from this vaccine. So, you know, and I'm saying this because I have a child, I have sons of this age, and I had to choose to get them vaccinated and boosted. So, you know, I can actually affirm this in this way, and did get them vaccinated and boosted, by the way. So here's our ask, offer, ask. Would it be okay for me to share some perspective about about the risk of your son having myocarditis after the vaccine? So you can see, like, very subtly shifted from cardiac death to myocarditis. Would you like to discuss some of the scientific rationale for offering this vaccine to young men despite myocarditis being a risk? Or can I tell you what I learned when I looked into the science surrounding this issue? Now, I'm giving all of these different choices because, you know, you have to decide based on the person sitting in front of you. And I've just got like this random, like, person I made on Canva. So, and then the answer, I've got some answers here. I'm not going to bore you by reading them because you're all public health people, and you know that the answer is that the benefits outweigh the risk. And then here's the ask, offer, ask. This is the ask. Do you have more questions? Do you have any thoughts about the vaccine with this information? What do you think about the risk of myocarditis in the vaccine versus the virus? And then this is my last slide. I just want you to know there's all sorts of misinformation you're going to encounter. We have a weekly newsletter. We do the top, that's why I was watching the Joe Rogan video. We do the top 3 pieces of misinformation circling every week in our newsletter. You can sign up for it under our resources tab at voicesforvaccines.org. And then we archive them. You can just search and you'll find all sorts of good stuff there. And I'm going to stop sharing now.
Hey, see, we still have time for questions. I'm going to ask 1 or 2 of my own, and then I'll ask, go to the chat. Karen and Dr. Jones, do you either or both of you think that vaccine hesitancy has put Minnesota at risk for a breakout of a preventable disease?
Yes, I mean, we were in this situation between 2017 with the measles outbreak. I mean, so it's not even a distant past. It's here, and there's pertussis in the western suburbs. Like it is out there, and so certainly we have a concern. Again, the data show we're better than a lot of states, but that doesn't mean that we can just kind of say, "Oh, good, fantastic, we did it." There's absolutely a lot of concern for that. And then the other thing to know is often these get started in, you know, as we all know, this is all just review, but the under or unvaccinated specific sub-communities too. And so again, that's where the kind of targeted outreach can be really helpful to address those, because those are often kind of the pockets where these kind of things come out of.
Another question. Did you have something to add, Karen? I'm sorry, I didn't need to speak over.
Nope, I agree. Cosign.
What public policies could the Minnesota Public Health Association do to engage elected officials to help us with these vaccines? Are there any?
I think, well, I mean, the big one that I always think of is I kind of alluded to earlier was the personal belief exemption, the non-medical exemptions. It's something that has been in our meeting, the Minnesota American Academy of Pediatric chapter, on our radar for a long time. But again, ability to partner with other groups to really advocate at that kind of legislative level is really important. So yes, there's a lot of pediatricians as part of the Minnesota AAP, but there are a lot of public health people. So we would be happy to partner with anyone really to work on that. I think that would be what I would say is my biggest one.
I put a link to a Minnesota Department of Health summary about the 2017 measles outbreak. I see we've got a comment that says, we go to vaccinate where the Latino population, for the most part, adults accept COVID. However, when it comes to children, specifically infants and toddlers, parents are very clear and firmly saying no. Recently, they've been offering some cash incentives, and then the no becomes yes. Is that an experience either of you have had?
I mean, I don't vaccinate people, but this is what I hear is that cash incentives or gift cards are really, really important. I think that we've done a really bad job of explaining to people that there are two groups of people who are at particular risk of hospitalization and death from COVID, those over 75 and those under 5. And it's it's sort of like it's RSV, pneumonia, COVID, and we've been really, really awful at it from the get-go. People under 5 years old just have those little tiny itty bitty lungs, and we need to take care of them. And and I think that that's some education that we could do in the Hispanic and Latino populations.
I,
Related question. Go ahead, Dr. Jones. Go ahead. Sorry.
No, I was gonna say, it is kind of fascinating because I have these conversations in the office all the time, and the number of people who say yes to that they themselves were vaccinated, let's say for COVID, for example, the parents will often say, "Oh, I'm not against. I did it myself. I've been vaccinated and boosted, but I don't know about my kids though." People will kind of do mental gymnastics when it comes to their children because be people are worried, and that's where these kind of conversations come in. They're saying, however you want to approach it with all the different strategies today. But one that actually I feel comfortable with, but other people may not, is to talking about my own family, what I've done for my own children. And so often that has actually been very helpful to say, I understand your concerns. I can tell you I've got 2 kids at home, both of whom were vaccinated the moment they were able to do that, and they've been boosted the moment they could. So sometimes that can help too, but you will absolutely find that people will do things very differently for their children that they would do for themselves when it comes to safety concerns. We almost like kind of overdo it a lot with our kids because people obviously worry about their children.
So we also have a question. Why is the uptake of the HPV vaccine so much lower than other vaccines? How can that be addressed? And somebody commented that they think it's because it's not required. You answered
That
your
could
question.
mean yes. I mean, I've Matt, you and I have done a lot of work with HPV actually. So, but no, there's the reasons for HPV kind of being lower they're vast. But you're right that not being required is important because when we require things, it really helps uptake. Now, there's a lot of ways that I find that reframing it in the office, talking about cancer prevention, talking about why it's important, because I get a lot of questions of boys. Like, I thought this was only a vaccine for girls, or it's only prevent cervical cancer, so I don't really need that. And then really talking about, the uptick in head and neck cancers, the lack of screening for that. So really reframing the discussion has been helpful. And there's been a lot of great outreach, even from, Matt's organization, the American Cancer Society, about working specifically for HPV, but it is an active area of work for vaccines and vaccine uptake. No, great question.
Karen, anything else to add?
I think that's part of it. I also think I'll just put out there, and I hope this doesn't offend you, Dr. Jones, that I think there's still a lot of provider I think there's still some provider hesitancy around, if not the vaccine itself,
Yes.
offering the vaccine, and I think that hopefully offering it at age 9 will help too.
That's one of the things that I've done a few talks about HPV stuff, and one of the things that I always highlight is the fact that we providers are not good. We are part of the problem. And this is true whether it's HPV that people are, aren't doing a very good job of advocating for, COVID as well. Absolutely. So we are not doing a very good job in the office about advocating. And the reasons for that are, there's a lot of reasons, but we have to often look internally ourselves to say, how are we doing, and are we part of the problem? And then how can we help so we address that? And so it's absolutely a very important point.
Another suggestion, another question, which I think you've addressed a little bit, but maybe there are additional comments. Any suggestions on wording for asking for permission? It says, I've used, would you be open to hear what I've learned on this issue?
Yeah, I think that's good. I mean, I think as much as you can make it specific to what the question is, that's good. Or, there's some research about this. Would you like to hear some more about it? Or would you like to hear how the vaccine works to, frame a little bit more about your concerns, those sorts of things. But just really asking, would it be okay if I share some more about this with you? Is sort of how I look at it.
We're almost at time, but I just wanted to ask, I guess this is more directly to you, Karen. Is there anything that public health people could do to encourage vaccination, maybe during August as National Immunization Awareness Month?
Absolutely. There's so many things. I don't have enough time to say. You know, uh, get out some chalk, go out into your street and paint a big or chalk out a big chalk mural that says "Everybody vaccinate."
August is a good time. Are there hashtags to look for? I guess maybe
Oh,
we'll find a better way to tee it up.
okay, NIAM 2024, I think is it.
All right.
NIAM.
Thank you, everybody, for joining us today. Thank you to both our speakers, to Karen Ernst and Dr. Jones. Really appreciate your time. Please take a few moments to fill out our evaluation to let us know how we did, and if there's other ways that MPHA can support your efforts to encourage people to get vaccinated. Thanks, everybody, for your time today. Have a great day.
Thanks, Matt.
Yep.
Thanks, Matt.